year-old lady who presented with CNS symptoms and was found to have this mass in the brain. And so, as part of workup, whole body workup, they did CT abdomen, CT torso, chest, abdomen, pelvis. And then they saw something in the liver at the hepatic dome. And so, of course, it was a single phase CT, wasn't clear what it was on CT. So sure enough, we got an MR abdomen. And let me zoom in. All right. Can you see the coronal T2 weighted images now?
Yes.
Okay, excellent. So this is the finding in the liver. At the dome, there is some vague T2 hyperintense signal abnormality, which on the axial is right here. It's not very well defined, not very well demarcated. And then there's another lesion right there. This is what it looks like on T1 pre-contrast images. It's fairly triangular, so to speak, right at the dome. And then here it is on diffusion. This is the B800 DWI. This is what the ADC maps look like. So no restricted diffusion. And then I'm going to show you the arterial phase. The portal venous phase right here. So any thoughts so far as we scroll through the post-contrast sequences? This is the more delayed phase right here. In a patient with a CNS mass and this liver finding. The CNS lesion turned out to be a lymphoma. And that was even before we did the MR, liver MR. Yeah, go ahead.
One thought I have about this one is sclerosing hemangioma, because it's T2 bright and it has a little bit of that nodular enhancement at the periphery and it has like this triangular shape.
Okay. Any other thoughts? Anyone else? There are more than one lesions. There's another lesion right here, but that also has a similar imaging feature, much smaller. The rest of the liver was clean.
Phase?
Say that again?
Is there a more delayed phase?
This is the most delayed phase. Okay. The one that I'm scrolling through now is the most delayed phase. In the background of known CNS lymphoma. Any other thoughts? Anyone else? The rest of the abdomen pelvis was clean. Say that again.
I guess lymphoma can look like anything, so maybe lymphoma, but it doesn't. Normally, lymphoma is more homogeneous and has more restricted diffusion.
Right. Exactly right. So Aarti, never doubt yourself. Whatever is your first instinct is usually right. So indeed, this turned out to be a sclerosed hemangioma. So we, up front, we hadn't made this diagnosis, and this was biopsied, and it was a biopsy-proven sclerosed hemangioma. So indeed, like you accurately described, it's very geographic or triangular. The margins are sharp, not thick. The margins don't look like a thick rind of soft tissue. They're sharply demarcated. And even sclerosed hemangiomas, some of them, so basically sclerosed or sclerosing hemangiomas are known to sclerose from the center out. And some of the vascular spaces give rise to the persistent vague T2 hyperintense signal abnormality within that lesion. The T2 bright areas can show nodular progressive enhancement. That's why I went through the arterial and subsequent delayed phases where there is progressive enhancement in some of the pools within that lesion. So indeed, this turned out to be a sclerosed hemangioma. So good job on that one, Aarti. I have a couple more cases. Excellent. So this is an older gentleman, came with epigastric and vague right upper quadrant pain. Got an ultrasound was negative, got a CT. CT showed this vague area right here. This is a single phase CT. Rest of the liver was fine. Any thoughts?
There's little capsular retraction also, no?
Yeah, absolutely right. So there is a divot here.
Yeah, so we think about like met, cholangio, and sclerosing hemangioma. Do you have any priors?
No priors. This was the first time he presented.
No labs either.
No labs, no other workup done yet.
Sent to MR.
Yes, indeed. Sent to MR, and I'll show you the MR. So here is the axial T2. Actually, let me, okay.
It's really
there we go.
zoomed in. Is that your intention?
Okay, no, it isn't. I'll expand the box, sorry. Okay, is this better?
Yes.
Yep.
Yes.
All right. So trying to hone in on that area because the rest of the liver was fine. You know, it's pretty vague on T2. You do see something there. You do make out a little bit of the capsular retraction. What one sequence, if you had to see, would you ask for? If you don't see this area very well on T2. So what has really helped me in livers in many instances, if I don't see something nicely on T2, I go to the pre-contrast T1. And many a times my experience has been, if there is a true lesion, I can see it very well on pre-contrast T1. So indeed, in that area, corresponding to the CT, we see something on the pre-contrast T1 right here. We don't see the capsular retraction very well. And I'm going to go straight to the post-contrast images. So here is the arterial phase. Portal venous. There's almost like a vessel going towards that area. But again, you don't see the lesion as nicely as you saw on the pre-contrast T1. The third phase right here. Nothing else in the abdomen. All other organs are fine. No lymph nodes. Lab work is negative. So how would you propose to report this finding, and what would the next steps be? So epigastric pain, right upper quadrant pain, all labs negative, and this is the only finding on CT and MR. Any thoughts?
I feel like similar to the last case, I would still think sclerosing hemangioma is in the differential, but malignancy is too. And so it's, and sclerosing hemangioma anyway is a diagnosis of exclusion that you usually have to biopsy to confirm. So I guess I'd bring those two up and then recommend a biopsy.
Okay, so at this point, they didn't do anything. This scan was done in August. And then the patient came back for a follow-up in December. And I'm going to show you the follow-up scan. So this is the pre-contrast T1. Now you see the lesion. I mean, just like the previous, on the previous scan in August, you still see the lesion better. It almost seems like the capsular retraction might be worse. Here is the diffusion. And the ADC. Sorry, our ADC maps are not the best in the world. Now that we have Victoria, we will improve them. So this is the post-contrast. Now you seem to see the lesion better. It has definitely grown. Here is the T2. Capsular retraction is worse. So at this point, between August and December, in such a short span of time, since the lesion was increasing in size, of course, we biopsied it. And this turned out to be a cholangiocarcinoma. So Aarti, just like you said on the previous case, we did propose both the differentials. We said this is either a peripheral intrahepatic cholangiocarcinoma given the capsular retraction, but there were no other features, tumor markers, everything was negative. And we also proposed a sclerosed hemangioma, exactly the two diagnoses. But at that point, this wasn't biopsied. For some reason, I don't know whether it was too small, too peripheral, not seen on ultrasound. But short interval follow-up, increase in size, and indeed, this turned out to be a cholangiocarcinoma.
I have a question for you guys about cholangio. Like, what is the, does anyone know what the growth rate is? Like, is it, like with a small one like that, if cholangio is in the differential, is it kind of okay to wait 3 months? Because it seems like even though it grew, it didn't grow to the point where it was now unresectable. And
right.
I guess it'll probably depend on
variable. I have a case that, cholangio grew over 7 years, and I have a case where it blew up in 4 months. So it's just very, very variable.
Yeah. So, yeah, I mean, I wish we agreed. This hasn't grown to the size that it's non-resectable, but it's always, you know, a little dicey when you see these vague lesions in the liver.
Yeah, definitely. That's a nice.
Yeah.
And these are harder when they are not against the capsule, like they're deep intrahepatic and you don't even see
Yeah.
the retraction.
Or they are upfront challenging to biopsy. You know, they are small, they're
High in the
upfront
door.
challenging to biopsy.
Do any
What,
of you use
what do you do
NucMed
then?
scans for this at all? Anu?
Say that again?
Do you ever use NucMed scans as a problem solving tools? Because like the NucMed colleagues tell us, only 50% or so sclerosing hemangiomas will take up the heat denatured RBCs. Sometimes we've tried that, but it's not really helped.
I haven't personally had an experience where I've used it for troubleshooting or tie breaking. Usually we'll end up with the biopsy.
Right.
Yeah.
Yeah,
But,
we don't use it either.
All right, I'm going to move on to the third and last case that I have. Not very subtle. This is a middle-aged lady presenting with abdominal fullness. And as you can see, we see this large lesion. Centrally, T2 bright, has a thick rind. I'll show you the axial T2, similar appearance, has liver going all around it. And then this is what it looks like on pre-contrast T1. Again, today's theme is liver lesions in a non-cirrhotic liver, right? Background liver is non-cirrhotic, no history of underlying chronic liver disease. Here is what it looks like on the arterial phase. And then we have the portal venous and the delayed phases. On both, it looks pretty much similar. So middle-aged lady, single, solitary, large lesion at presentation with central necrosis. You know, it's unfair on my part to ask what this might be, but any thoughts? You know, what differentials would come to your mind when you see a solitary, large lesion in a non-cirrhotic liver? This doesn't look like a giant hemangioma, so that's out.
Kedar is saying MCN.
Okay, that's a good thought, except MCNs usually do not have such a thick rind. You know, they are mucinous tumors, and so they are more T2 bright. They typically do not have this thick rind, but that's a great thought. In a female.
Any infection?
Infection, yes, this could be a large liver abscess.
Yeah.
The only thing is she didn't present, you know, she would have probably presented earlier, not waited for the abscess to be large. Although I must say, Rupa, I have seen in India, amoebic liver abscesses present like this. But
it almost looked like they were like small, like daughter
cysts.
Right. Things, I don't know if those are vessels or.
I'll show you the post-contrast. Those are just necrotic areas, not vessels.
To me, that rind looks really ugly, like evil gray. And I'm thinking about like sarcoma.
Yeah, I agree. You're on the right track, indeed. You know, this is, number one, it's not a benign lesion. It has a very thick, ugly rind. Number two, the good news is it's not invading into anything outside the liver. And therefore, this went to resection. And this turned out to be a solitary fibrous tumor of the liver. Of course, I'm going to show you something rare, right? So even though this is rare, when I looked at case reports and when I dug into literature, all of them look pretty much similar because apparently their growth rate is fast. They grow fast, and therefore most of them, like the images that I saw in case reports, have this central necrosis due to their fast rate of growth. They're more common in women, middle-aged women, present typically when they are large in size. Because perhaps of the growth rate as well. Now, solitary fibrous tumors are more common in the pleura. There are extrapleural sites that have been described. There's a nice paper, Shweta Bhatt wrote a paper in AJR in 2007, and she has shown multiple examples of extra thoracic solitary fibrous tumors in the CNS, nasal sinuses. She also shows us one example of a liver fibrous tumor. So anyhow, in brief, this is a rare tumor. It arises from the liver capsule, the inner lining of the liver capsule made of spindle cells, fibroblasts, and at presentation typically is large. Most of the times is peripheral and so can be excised. These can be benign or malignant. In fact, this person had a single met in the lung, which was also excised. And fortunately, they are doing very well. They keep getting follow-up scans, but hasn't recurred so far. And then immunohistochemistry, biopsy is one option. This can be biopsied before surgical excision. And immunohistochemistry apparently helps in distinguishing this from an angiosarcoma or a large GIST. And then fibrolamellar HCC is in the differential, but commonly seen in younger patients, not this age group. So the demographics helps in distinguishing the two. Yeah, any questions?
That's very cool. I have two huge SFTs of the liver, but mine don't have central necrosis. And I have other ones that were like in the retroperitoneum with central necrosis. So my takeaway is that I think there's like two types, maybe one that's more rapidly growing, and the other one that's more of a solid, like truly diffusely solid mass. And the diffusely solid one tends to have delayed enhancement, but be fairly T2 bright. And then some of them also have this central necrosis. So
okay, awesome.
Nice.
Maybe you show us those some of the time.
Yeah, definitely.
Okay, that's it for now. I'm going to stop sharing my screen.
I heard Gitanjali and Victoria also have cases. Either of you want to go?
Well, I'm all set, but I can go later after Gitanjali.
Yeah, I can share mine.
Okay.
Okay, so first case is young female, 22-year-old female who had this incidentally detected pelvic mass. This was detected during pregnancy and was biopsied at the time of C-section, and this was a follow-up later on. So differentials. I'm not sure where these, what are these clips from? Maybe at the time of biopsy, I don't know what kind of biopsy they did, or prior surgery. That was the only history available at this point of time to us. That, but we had the biopsy report, which is
surgery was a C-section, Gitanjali.
No, like, but the clips are on the side, Dr. J. So
they had partially excised it.
Okay, they're partially excised. Therefore, I think it was probably an excision biopsy. So any thoughts on what this could be? This is a PET that was also done as a follow-up. Really didn't show a whole lot of activity. Young female, pelvic mass. And then since I'm not, one second, let me pull up the chat box. Yeah, I didn't see anything in the chat box. This was another follow-up MR of this patient. So maybe MR helps in better tissue characterization, and if anybody has any thoughts on what this could be.
I feel like someone showed one like this before, and that T2 brightness is making me think of like an angiomyxoma. But are there other lymph nodes next to it? There's like multiple lesions or something.
Yes, there are other lymph nodes more proximally there.
Oh, and is it avidly, and that's T2, right? Not post-con.
Yes, these are both STIRs. Yeah, there is no post-contrast along with this MR, but I have one more MR, another follow-up couple years. So now it's been 10 years since that first CT that I showed you. And we read this MR today morning, and this is a follow-up MR on that patient. So this is the post-contrast that we have.
Because I was thinking with the lymph nodes like Castleman's, but usually Castleman's is avidly enhancing.
Yes. Yeah, this was Castleman's. The reason I was going to say that this is misleading post-contrast image, that it's not showing enhancement. Castleman's is usually avidly enhancing, but as I said, this was a 10-year follow-up for this patient. So she's been treated in multiple ways since Castleman's is very vascular. They've even attempted embolization for this just to decrease the size and relieve the mass effect. As we saw in prior CT, it was causing quite a bit of mass effect on bladder and uterus. So just to relieve the mass effect, they attempted embolization, and that's the reason why it's not showing enhancement, but showing other diagnostic imaging features that you have enlarged very cellular looking lymph nodes, but the shape of the lymph node is maintained. It still looks like a reniform shape of those lymph nodes with the hilum somewhere here, and there are other enlarged lymph nodes adjacent to it. The main treatment for Castleman's disease is newer drugs, those MIBs and MABs. I have a quick review of Castleman's disease here. And we have seen that before. It's monoclonal lymphoproliferative disorder, which is non-neoplastic lymphadenopathy. It's also known as angiofollicular lymph node hyperplasia or giant lymph node hyperplasia. That's the name that I always keep in mind because health helps in diagnosis whenever you see enlarged, avidly enhancing lymph nodes and the shape of the lymph nodes is maintained. That's when we think of Castleman's disease, especially in a younger middle-aged person. It's of two types, unicentric and multicentric. Majority of them, 90% are unicentric. They're most often in younger individuals in third to fourth decade. The presentation is more in younger age group, and it's often picked up as an asymptomatic mass and has a benign course, as in this case, it was just detected incidentally during pregnancy. It's the multicentric one, which are the rare type, which presents with more profound clinical presentation with more systemic symptoms of fever, night sweats, fatigue, because it's just diffuse disease, multicentric disease, resulting in a lot of B symptoms, like as you see with lymphomas and other disorders, presents with generalized lymphadenopathy and even hepatosplenomegaly. The histopath classification is hyaline vascular and plasma cell. Hyaline vascular, again, is the more common one. 90% of the unicentric ones are hyaline vascular. Most common location for this is mediastinum, and what we see is avidly enhancing enlarged lymph nodes. And plasma cell is again more often multicentric. These are less enhancing, but more symptomatic. So treatments, as I was saying, are these MIBs and MABs, so systemic chemotherapy, anti-proliferative agents, including anti-IL-6 and anti-CD20 antibody therapy. So this patient was treated with one second, I had that name somewhere. It was an interleukin-6 medicine chemotherapy agent that was that she was treated with, and I think it's just to control the disease. The decrease in the size has been, I think, because of prior intervention, but yes, it doesn't, probably not showing great response to treatment at this point of time.
Very cool. I wonder why they only did a partial resection. Like, I guess maybe intraoperatively, it doesn't really look like a lymph node. So they weren't like, I don't know.
Yeah, they weren't sure.
So
what
Aarti, I
they
think
just
what
wanted
happened
to-
was, so the lymph node mass is stuck to the ureter and to the iliac artery. So
oh yeah, that's the reason why
they
not
resected
completely
half of
excised.
it and they couldn't resect the rest of it.
Yeah.
Got it. Cool.
Another case, that's a quick one. There's more of like a, like I would like to know how will you all read this out. 50-year-old female who presented with these multiple pelvic nodules. These were incidentally detected again. She had some left hip issues and this left hip MRI was performed and somebody saw these nodules in the pelvis. So they did a dedicated pelvic MRI to further evaluate these. Hope I'm sharing the screen, right? Yeah.
Did she have a hysterectomy for fibroids?
Yes, she had hysterectomy for fibroids.
So they could be parasitized. They're not as dark as I'd like them to be on the T2, but they do look nice and round and homogeneous.
Yeah, these were leiomyomas. So I was like wondering, like, so is this a known presentation of leiomyomas parasitized at the site of surgery?
Yeah,
We weren't sure. Like we thought we just some nodules, maybe malignant. We need to biopsy. Not sure what these are, but these just turned out to be leiomyomas. So I thought that was interesting.
Yeah, the other thing I would think about here is splenosis, you know, like because they're so homogeneous and they look like they're restricting. But I think like, especially if you have a lot of fibroids and you remove the uterus, their little ones could be left behind or dropped and stuff. So yeah, I've seen this before.
Okay, yeah. So I had never seen this, so I thought it was interesting that she was 52. They like worked her up. All the markers were negative. CA125 was negative. Really not arising from the ovaries. Her ovaries looked okay. So yeah, these were leiomyomas. And another one. So this young lady had these again. A leiomyomatous uterus. She was being worked up and evaluated whether uterine artery embolization can be performed. She presented with abnormal uterine bleeding. She also has history of endometriosis. So after this scan, she underwent myomectomy for this, and she had endometriotic cysts in the right ovary. They did some debulking surgery. But the op note said that she had extensive pelvic endometriosis. Again, we don't see much evidence on MR, but she did had a lot of adhesions and
that looks more like an adenomyoma to me than a fibroid. Like not that, I don't know.
Yeah, they're more localized, but like see more in the anterior wall. I don't know, I've not seen adenomyosis localized to the anterior wall. This is the endometrial stripe. Again, they did, let me check. So they did myomectomy. Yeah, the path said cellular leiomyoma. So this was.
Looks like leiomyomatosis, but it's only affecting like the front side of the uterus.
Front side, yeah, yeah, more extensive. Like some are, this is probably the more classic, like darker, and these are more like brighter, so more cellular areas here. And again, not one discrete, maybe confluent of multiple, or as Steve said, maybe leiomyomatosis. So the other, I need to go this side. Okay. So then she, after 2 years of surgery, she again presented with abdominal pain after her history of myomectomy. It still shows a bulky uterus. Ovaries have enlarged, but again, they thought it's probably her endometriotic cyst getting worse. We'll start seeing some outgrowth here on in the fundal region, and then she was put on OCPs for so that her cysts get better and she has symptomatic improvement. But her symptoms of abnormal uterine bleeding, abdominal pain didn't subside, and this is another follow-up CT couple months after that CT. So again, here the question is, how would you read this out? She had previously biopsy proven cellular leiomyoma, for which myomectomy was done, and she was put on OC pills after that.
I don't know what the time interval is, but whenever you see a rapid change in leiomyomas, you worry about a sarcoma developing in there.
Yeah, that's exactly our worry was like, is this sarcoma developing in here? It's causing like, a breach in the uterine contour on the fundal side. So time since the first presentation, it's 3 years down the line. This was 2 years, and between this and this is a 1 year follow-up. So it is a rapid growth.
Yeah.
But again, this also on biopsy turned out to be just benign leiomyomatosis. And the only thing that they mentioned was that it had epithelioid cells. And I think, again, I have a review here, which I have done it before, but just a quick revision of what we have seen in the past, that on a histopath, these are some of the things that the pathologists look for: the mitotic index, how many mitosis per 10 high power field, degree of cytologic atypia, like is there mild, moderate, or severe, and presence of tumor cell necrosis. And based on that, you have different terms that they use. If there's no worrisome feature, it's a leiomyoma. You can have variants where it's more cellular, or it can have bizarre nuclei, or they're mitotically active. Or stump is when it has 2 of the 3 features being abnormal, like if the mitotic index is high, or there's atypia, or there's cellular necrosis, but only 2 of the 3 features present. And if all the 3 features are present, then they call it as leiomyosarcoma. Again, imaging, it's hard to differentiate one from the other. There's some suggestive features, but nothing definitive. So in this one, they said there was the mitotic index was low. It was only 2 per 10 high power field, but there was mild cellular atypia throughout, and there was tumor necrosis. So they eventually end up calling this as a stump lesion.
I have a comment about the growth thing. Can I share my screen for a minute?
Yeah, sure.
Okay.
Yes, I stopped sharing.
The growth thing, huh?
Okay, so this is up to date. This is like a copy of an up-to-date article, a recent up-to-date article on fibroids. And basically they say this thing about rapid growth being suggestive of a leiomyosarcoma does not pan out. This is not substantiated in, for example, the study of 1,300 patients. Because they say basically that leiomyomas can grow and shrink at differing rates up to 138% within 6 months. And therefore, just based on leiomyomas being common and being commonly growing, growth should not be used as a factor for suggesting that a patient has a leiomyosarcoma.
So throw that one out, and all we have is if it's gigantic, irregular, and eating surrounding structures, then it's a sarcoma. Otherwise, we're lost.
Yes, and also, by the way, this is just premenopausal patients. A growth in a postmenopausal patient is very alarming because it should not be getting hormones and responding. Right. But premenopausal patients, leiomyomas can grow rapidly. So yeah, I know I found it interesting because we had a rapidly growing one too, and then I read this up-to-date article, and now I've thrown that out. So.
Yeah, in this case, my question was, is it because of prior myomectomy? Because after myomectomy, they can again like parasitize or move out of the uterine cavity. Maybe that predisposed it to look that aggressive or.
And you know how you said it was a stump in the end? Is that like pre-malignant? Like basically that is pre-malignant. So maybe that's also why it was busting out, which we don't usually see.
Yeah, they eventually said it. No.
Cool. And I interrupted you, Gitanjali. Did you have more cases?
No, that were all. That's all I had.
Awesome. Okay, Victoria. And then Kedar has a follow-up to news after Victoria, and then I have a couple after that.
Okay. Screen. Advanced. Option screen. Can you see it?
Yes.
Can you hear me okay?
Yep.
So this is just like a crazy case. There's really not much that we can learn from it for the future, but it's just an insane case. So what would you think when you see such a case?
It's looking like a pancreatic adenocarcinoma.
It does, and that's what it was bred as. And patient underwent pre-op chemo RT. This is the immediate follow-up scan. You can see that, you know, there's a fiducial marker. The tumor itself looks like a trunk. Right now, there's a post-chemo steatosis. Patient did go for surgery. So what do you think the path is? The path was, I mean, crazy. It was high-grade pancreatic intraepithelial neoplasm without frank malignancy. So this patient, this is 6 years ago, so patient is completely stable, you know, gets follow-up, whatever. So this is just an absolutely insane case because it looks like adenocarcinoma. There's, and every time you'll see it looking like this, it will be adenocarcinoma. But this patient somehow lucked out that he's very aggressive looking adenocarcinoma ended up being precancerous rather than fully frankly cancerous.
Victoria, I have a question.
Yeah.
Here, they won't give chemo or radiation unless you have a biopsy proven adeno before. So there was no biopsy before?
Yeah, that's generally true with us as well.
I agree. This isn't, you know, fairly old case, so I don't know exactly what happened. I remember that there were atypical cells, I think, on FNA. I presume that was enough for them to go.
Yeah, occasionally they will initiate treatment on atypical cells in a very classic presentation.
Right,
Yeah, but I'm not sure I completely buy that this was never a cancer, because after chemo and radiation, you can get basically where you don't see any tumor cells left. Like I've seen it where we have a biopsy-proven cancer, they get chemo and radiation, and then the final path is very little cancer left, or sometimes no cancer left, you know, like where it's all post-treatment change. So
this wasn't
after being treated, getting a final path, I'm
Right.
not sure I believe that there was never cancer there.
true, but the result was they certainly had not like quite a bit of PIN in the sample, but not malignant cells. I agree with you, and the patient is doing great. The patient is out 6 years without any recurrence. So it's just a kind of a lottery winner kind of situation here, as far as I'm concerned. If there was cancer, I guess the degree of cancer was small enough that patient's doing well. But again, on the final path, they just had high-grade PIN in the entire sample, which was sort of insane. All right, so the next patient is an HCC patient, as we all know about the HCCs. And, you know, it's not a diagnostic dilemma. We have this very large mass. It's a solitary mass. I forget what the patient's underlying liver disease was. But you can see that we have these, you know, very heterogeneous appearance. We have these big vessels coursing through the tumor. And patient had, let's see, this was an outside study, so I don't know if there was a portal venous phase, but on subsequent post-treatment studies, there was washout. Patient had downstaging TACE and then ended up having a resection. And then a few months after resection, this is what it looks like. This is a resection margin. You can see that there's a large tumor at the resection margin, and there's just humongous peritoneal metastases, not shockingly, you can see here. So the teaching point that I'd like to share with you here is that there's something about this lesion that can sort of raise our concern that this patient is not going to do as well, besides just having a large tumor. But these large intratumoral arteries, as you can see here, there are some recent studies that show that presence of these large intratumoral arteries is a bad prognostic indicator. Patients have higher risk of recurrence post-treatment with this finding, and patients get an overall poorer survival. So that's just to make you aware that there's a emerging literature on HCC where we're shifting away from purely diagnostic approach to getting some sort of prognostic data on these patients.
Very cool. Victoria, you said that they were treated with TACE, which makes sense when you see such a vascular tumor too. But is there something else that, I guess we could add some anti-angiogenic thing, or is there a different way they would treat these if we see that sign?
I don't know if at this point there's anything that can be done differently. I think that once a better prognostic models are established, I can start throwing in early, early systemic treatment situation. But I don't think yet this is a mainstay treatment. But this is something that I don't know. Maybe if you're following a patient like this up and you are seeing something that you are, you're unsure, then you should, in such cases, because of the heightened risk of recurrence, just err on the side of caution and be very, very vigorous. I think at this point, this is as much as we can go. But eventually, I'm sure this is going to contribute to difference in different treatment strategies.
I joined a little late. I have a tangentially related comment about TACE for HCC. I was talking to one of our IR colleagues, and And here, I guess we don't do TACE anymore. We just do Y90. Is that, have you guys had that experience at your institution?
I think it's institution specific. Like at Montefiore,
Yeah.
TACE was a very beloved approach. At some places it's ablation, at some patient, the tear, the radiation therapy based approaches are gaining, gaining preference. So I think it's institution specific. There's really not, at least I'm not aware that there's a strong data. I know there's some data that shows TACE is not as great for larger lesions. In that patient, they didn't do TACE as a definitive treatment. I think it was a, TACE as a, let's make it less vascular so the patient doesn't bleed out on a resection table TACE.
IRRs tend to TACE most of the smaller lesions. Once they get above a certain size, I couldn't cite what threshold, they move to a little bit more Y90.
I mean, from my experience, Y90, I mean, it just does a phenomenal job. I mean, these tumors, I mean, they respond so well to Y90. I'm so impressed.
Yeah, we are mostly using Y90, and Kadar just said also in Arkansas, they're mostly using TARE and then rarely microwave or cryo. Yeah, well, and we'll use microwave for the smaller ones too.
It really, I think, is institutional preference in many cases. There's also a lot of interest in SBRT. Monte, when I left, was really gaining momentum with that, and Beth Israel, so they do quite a bit of that. All right, so my final case is on a patient who didn't read a book, textbook. So this is the lesion in the tail of the pancreas. So the PAX may be misbehaving because, but this was a lobulated kind of hyperdense.
Needs an MR.
Agreed.
Got it. Here's an MR. And I'll tell you that the patient is a middle-aged dude in his 40s, if I recall correctly, and he's a dude for sure. I don't think, so we don't have the contrast MR, we just have the T2. I mean, this is kind of the key sequence, that I'm showing you here. I can extend and show you the T1 here. So any thoughts? Actually, I can't show you T1 somehow. This is an outside study, so they
And you said they didn't do post contrast.
not on MR.
Okay. On the CT, it looked lobulated, and I was almost suspecting a serous adenoma.
Yeah.
Here, this looks weird and
A little frond-like.
Yeah, I don't like the periphery, like a rind.
I can't get off the idea that this could be an endocrine neoplasm.
Yeah, I like NET and also SPEN.
Yeah.
So, this was resected, of course, and this ended up being SPEN, which I guess the clue to it is the T2 hyperintense thing in the retrospect. But as I said, this dude didn't read the book because he's very in a very incorrect demographics for SPEN. But weirder things have happened, so we need to keep an open mind. So this was a path proven SPEN in a 40-something-year-old man, which is not typically, but if I told you that this was a 17-year-old, teenage girl, who's African American,
Got there quicker.
right? I think you would just got exactly where it is, very, very quickly. So. Anyway.
So I have a comment about that, which is that I think that demographic thing is not true anymore. I was reading a pathology book that said that the African American thing is not true. It's like the WHO classification books. That's what they said in there. And then also, I think the demographics is like 85% female, 15% male. So I don't think that we should say, the only thing that I really hang my hat on the female thing is mucinous cystic neoplasms. So I have seen a bunch of spens in males now. So, and the third comment I have is I think the T1 would have been helpful because that central part is probably hemorrhage from outgrowing their delicate vascular fronds. And so usually if there's hemorrhage centrally, then that can really suggest a spen.
I don't disagree, but you know, we're going with you get what you get and you don't get upset. This is as far as they got us. Just somehow only the second.
Yeah, I'm just saying for just for like general.
Absolutely, absolutely. I mean, it would be, you're right. It would, you know, and then if we gave contrast, there would be a lot of solid tissue here. But you know, this is what we got. And I don't know, this is cool case.
I'm just being ordinary today, and I'm debunking all sorts of myths.
Good. The myths,
Like you gotta do myth, that's your next talk, I think. Mythbuster radiology.
Yeah.
no, you know, Artie, that is an unbelievably awesome topic for a talk.
Yeah, I guess my
No, very.
No, but my general philosophy nowadays is like I love up to date and I love these WHO pathology books because they have a lot of true information that I feel like we have a lot of myths in radiology, and then we just quote other radiology papers. But if you go to the actual, you know, like the pathology sources where all of these tumors have to get submitted to the WHO, I found those books to be really helpful. So anyway, just a general shout out for them.
Okay, but still, you know, I think about this as a maybe SAR workshop proposal. I would
I'll let you know.
100% attend this.
I'll let you know. I'm workshopped out at the moment. Okay. Oh, Nelly has a case, and then Kedar is also going to. Nelly, were you going?
This is a patient who, what?
You're going, right?
Yeah, I think so. Am I sharing my screen? Sorry if I,
Yeah.
well, you know, I joined a little late, so I didn't know if there was a lineup. So I just took the screen, if that's okay.
Yes, go.
Okay, cool. Yeah.
I have
What?
a theory on this, but I'm going to keep quiet.
On my case? Great. Okay, sounds good. Okay, this is a patient who had an elevated PSA and then got an MRI.
I think Ben might have actually shown this case.
Oh, he did? No! Sorry, doing a
Does
little.
anyone
Okay,
else
I
remember it? No, it's good. It's a good case.
Wait, when was this shown? Oh, previously. All right. Well, I have additional, I guess, discussion points. I don't know what was discussed at the. I think I missed it. I probably missed that case conference.
At the time I said I thought this looked like a giant cystadenoma of the prostate. Yeah. And then I'm not sure if he had path proof at that time. So do you have path proof?
Yeah. So the biopsy showed biphasic tumor. So I'm going to show you. Where's my Google? Here it is. Okay. So I had to look it up. So our pathologist said a biphasic tumor. So it had a stromal and it had an epithelial component. So that I guess that's what makes, you know, tumor biphasic. And a MES tumor is a form of biphasic tumor. And I said, well, you know, can this, you know, what about stump? And she said, yeah, that's usually stromal, more stromal than epithelial, but that, you know, that would be along the same spectrum. So either way is benign or indolent, and so we're not going to get surgical pathology on this because we're going to just watch this.
Oh, they just needled it. They didn't do a.
Yeah, it's just transrectal. Yeah.
So it's not a giant cystadenoma. It's basically some combination of an epithelial and stump
stromal.
Okay.
Yeah, biphasic tumor.
Almost look like the world's largest extruded nodule.
Yeah, that's why I thought about stump, because they look like a giant BPH nodule. So, okay. Like I said, we're just gonna watch this.
Cool, Kedar, you want to go?
Yeah. I have also shown this case not too long ago, but since Anu showed the case, can you guys see my screen?
Yes.
Yes.
Okay, so this was actually a patient with myeloma, and they had this liver lesion, and this looks more like a T2 hypointense lesion, T1 hypointense, and enhances intensely on arterial phase, but then on the delayed completely fills in. And this was the PET. Well, we get PET for, of course, every myeloma patient. So this was actually taken out, and this was a solitary fibrous tumor of the liver. So more typical looking.
Yeah, this is what I was saying. Like I have several that look like this with that nice delayed enhancement. And then the T2 can be variable, like dark,
Yeah.
but also it can be fairly bright.
Yep.
But then
that
other
was-
ones like Anu's are centrally necrotic. So, okay, this was KUB I was reading for G-tube placement. And I didn't know what this tube was. Does anybody know what this tube is?
Kind of looks like a pigtail drain. I don't know why they're putting that down there though.
Exactly. I was
Thinking
like,
the same thing.
yeah. So then I go to the IR jacket and I see this and I'm like, did they do a thyroid biopsy? So does anyone know what this is? This is actually kind of cool.
The
What is-
esophagus?
What'd you say?
Esophagus? Is it a percutaneous
A
drain of some sort?
transthyroidal.
Yeah, exactly. So this is the carotid, this is the needle, and this is the esophagus with air in it. And they're accessing, using ultrasound to access the esophagus. And so this is what they call a PTEG, which is a percutaneous transesophageal G-tube. And they do these rarely, but they do them occasionally here. And basically it's for patients who don't have access to their stomach percutaneously. So either they have a lot of ascites or they have overlying bowel. So this is this patient's CT and multiple CTs. And there was always just like no window and all this bowel overlying the stomach. And so they went, so this is for a long-standing G-tube. You can't just leave the NG tube in, that'll cause like nasal erosion. So they percutaneously put it into the esophagus in the neck. And then this is what it looks like in the end.
Wait, so per oral was not accessible? I mean, patient had like head and neck cancer or something?
I don't think you can leave it in long-term per oral.
Oh, just kidding. Sorry. Just said that.
Yeah, I think you can't leave it long-term per nasal or oral, so they can, but they can leave it long-term through the esophagus in the neck.
And, you know, this comes up from time to time, but I'm not sure if I've seen our IR folks put one of these in. So I'm going to suggest it now.
I know. I was like, what is this? And I was just really perplexed by this. I was like, why are they doing a thyroid biopsy at the same time? And then I was like, oh, this is the esophagus. This is so cool. So anyway. Okay, this is my next patient. This is not an eye test, but just kind of a dramatic example of a large fluid collection involving the prostate.
Is that like prostatitis gone really wrong?
Yeah, so this is a really, really bad prostate abscess. And then you can see too that the patient has lymph nodes here. And so, you know, we looked in the chart and this patient does have HIV. So people who get prostate abscesses, it's much less common now that usually prostatitis is treated with antibiotics. But if it does happen, it's usually in 50 to 60-year-old diabetics or immunocompromised patients. One thing you can do to treat it if it's smaller is they can do a transurethral resection. So they'll go, so we tell them where the abscess is and then they cut that part of the urethra and the pus drains out of the urethra. This was too big, so we ended up putting in a percutaneous drain and it treated it beautifully. And there was basically no abscess remaining. But yeah, this is a narrow window here. So just be careful of the rectum, all these vessels. Anyway, so that was so you can either do it that way, or you can also do transrectal. So that would be another possibility. You can put the drain through the rectum into the prostatic abscess. And that's a little bit more comfortable.
Transrectal drainage just before.
You have, is that what you said? Yeah. Yeah, we've done a few this year and they worked really well. Okay, this is my next case. This was a liver
Kind of
issue.
infiltrative, but there's vessels kind of running through there too.
Exactly. So my trainee was like, oh, there's a big mass here. Maybe it's an infiltrative HCC. But you
MRI.
Yeah, exactly. So there are vessels running through it. So I told him, okay, the differential of vessels run through is fatty infiltration, lymphoma, and then certain infiltrative cancers like HCC could do it, but would probably have invaded the vein by now, or lobular breast cancer. So they got this MRI, and you can see that there is, we put the in and out next to each other. You can see that there is diffuse steatosis, but with more
Geographic fat, yeah.
Geographic fat deposition. So I don't know why it shows that part of the liver, but it did. This patient actually also has alcohol abuse, but I didn't know if that meant, if that, I don't know, has more of a predilection to the right side of the liver or something. But anyway, that was that one.
After you show that metastatic breast cancer case, that I was like, now I'm just going to recommend MRI every time I suspect.
Yeah. And in that other case, like, there was actual abnormality on both the T1 and the T2, whereas this, you can just see it's like just fat, and just happens to be more. This one, there was this kind of unusual appearance, geographic appearance of one lobe versus the other. And so I just thought this was a nice example where, like, it looks like this is the hypoenhancing abnormal part of the liver. But as we go to the portal venous phase, we can see that there's actually a big thrombus. This patient has a hypercoagulable disorder, and the thrombus actually goes all the way into their splenic vein and into their SMV. But you can see that the portal vein is thrombosed on the right, and it's preserved on the left. So the hepatic artery is taking over on the right. So this appearance that we're seeing on the arterial phase is the hepatic arterial buffer response in the right lobe. So this is the abnormal lobe, and this is a clue that the portal vein is out on that side.
Pretty stark, extreme example of that one.
Yeah, I thought it was a good example. And then, like, it usually kind of equilibrates. Yeah, see, it's pretty equilibrated here, so that you see the buffer response most robustly on the arterial phase.
Arti, do you have diffusion?
We should. Let's see. Oh yeah, our thrombus is restricting, which is non-specific. So you can see that in both bland thrombus and tumor thrombus. Yeah, nice example.
Hey, Arti. Unrelated. This is Siemens, right?
Yes.
Right. I'll have to get back to this with the specs for the DWI.
Oh, sure. I mean, like Anu was saying, our ADC sometimes is not nice, but this one happened to be pretty. So
the DWI images are great. So
thank you.
anyway, I'll hit you up for some information.
Yeah. Okay, it's 3 o'clock. We're gonna stop, or I'm gonna stop. Anyone have any final comments? Okay, I'll see you guys later.
Bye, everyone.
Bye.
Thank you.